This is Dr. Christopher Sendy with Nova Health Recovery Ketamine Infusion Center in Alexandria, Virginia, and I'm going to talk about ketamine infusions versus ECT, or electroconvulsive therapy, shock therapy otherwise as it's known, for depression, and which one is better. Well, the spoiler alert here is that a recent trial demonstrated that ketamine therapy was non-inferior to ECT, which is the gold standard for depression therapy in patients who are suicidal or have psychotic depression or severe treatment-resistant depression. And this was a recent article, May 24th, 2023, in New England Journal of Medicine that was a randomized trial that compared ketamine infusions to ECT. So ECT, electroconvulsive therapy, is what it is. It's basically electrical therapy to the brain. It works well in patients that are older, generally in inpatient settings, in psychotic depression, severe treatment-resistant depression as well. And it's considered to be the gold standard in treatment of severely depressed and suicidal patients. Now, ketamine infusion therapy is also been found to be very effective as well. Ketamine infusions are a safe and rapid way to achieve effective results in depression treatment, and definitely is more effective from some meta-analysis than current available therapies using intranasal ketamine. A series of 6 or even 8 infusions 2 to 3 times per week at 40-minute infusions at doses from 0.5 milligrams per kilogram up to 1 milligram per kilogram is generally the protocols that are used for the treatment of depression, the main side effect being nausea and dizziness. So people can't drive for several hours after an infusion, mainly just because of nystagmus and difficulty with coordination and balance. The effects are generally seen by the 3rd to 4th infusion, and anywhere from 50 to 75% of patients may have remission or significant improvement with this treatment. It is, again, a treatment, not a cure. There are no cures for depression, but the goal is to get people in remission so that they have a good quality of life and are symptom-free, but still may require medications. Now, a recent trial in the New England Journal of Medicine compared ketamine therapy with ECT for non-psychotic treatment-resistant depression. And it was an open-label, randomized, non-inferiority trial, which is a statistical thing, meaning that this wasn't really powered to figure out whether ketamine was more powerful than ECT in terms of its response, but was it inferior or not inferior to ECT? And so they basically took treatment-resistant major depressive patients without psychosis, recruiting them, and either gave them ECT or ketamine therapy. And there was a 3-week treatment phase in which you either got ECT 3 times per week or ketamine therapy at a dose of 0.5 milligrams per kilogram body weight over 40 minutes twice per week, which generally is a little less than we offer. Usually 3 times per week is just kind of clinically been found to be more effective, but they chose twice per week with the ketamine infusions. Now, the primary outcome was a response to treatment in terms of a decrease of 50% from baseline of the QIDS, the Quick Inventory of Depression Symptomology Self-Report Score, which ranges from 0 to 27. And so the goal was to get a 50% decrease in this scoring system. And they effectively had secondary outcomes as well, which included memory tests, other depression tests, as well as patient-reported quality of life, and they followed these patients for over 6 months. The results, effectively, as I said at the beginning, ketamine was non-inferior to ECT as a therapy for treatment-resistant major depression in patients without psychosis. So here we have our ketamine versus ECT protocol, and we ended up with basically some 403 patients total. 200 of them received IV ketamine, and 203 received basically ECT, and a certain number of them kind of did not go through the trial, but it was a small number. There were more patients chose not to go through ECT after the randomization than ketamine for logistical reasons and other reasons as well. But that said, the dosing again was the 0.5 milligram per kilogram IV ketamine twice a week for 3 weeks in the ketamine therapy group. And the ECT patients basically got their ECT 3 times per week for 3 weeks. And it started as a right lateral type of brief pulse, but actually could escalate to bilateral ECT in some patients. The average patient age was 21 to 75 years of age, and they all had major depressive disorder without psychotic features. And generally, with treatment-resistant depression, we're talking about 2 medication failures. And the patient's average Montgomery-Åsberg depression rating scale, which is another depression score, was greater than 20, meaning they were pretty depressed. And that was their inclusion criteria. So again, obviously, we are comparing an effective treatment for depression, which is ketamine, with the gold standard for severe depression, which is ECT. So the measured areas of treatment were depression scores. Did people end up less depressed in either remission or improvement? And also global measures. How did the patients do on 7-point scales for their general global impression and improvements? And also memory loss. We know that ECT is associated with some memory impairment afterwards. And ketamine has evidence for actually being pro-cognitive in many cases. And of course, quality of life, where the patients improved in their quality of life. And so there were a number of different scoring systems that they used here in measuring primary results, which was the QIDS result for depression, and secondary outcomes, which was the MADRS scoring, as well as global measures such as the Clinical Global Impression Improvement Scale, as well as the Global Self-Evaluation of Memory for memory scoring as well. So what were the results of the ketamine versus ECT study? Well, in the primary results, we found that in the QIDS response, that for ketamine, that approximately 55.4% of the ketamine group versus 41% of the ECT group actually had response. So a significantly larger number of ketamine patients had response relative to the ECT results. But these, again, was just designed as a non-inferiority trial. So obviously, in this case, you can see that ketamine is not inferior to ECT results. Ketamine actually had a 55% response in decreasing depression scoring. Further depression response measurements demonstrated by the MADRS scoring that 50% of the ketamine group had response on the MADRS depression score, whereas only 41% had response with the ECT scoring of MADRS. And as far as achieving remission, which means no symptoms, 32% of ketamine-treated patients after the series of infusions actually were in remission, whereas only 20% of the ECT patients were in remission at the end of the series of ECT system shocks over the 3 weeks. Now, the other outcomes were memory impairment, and it was found to be worse in ECT. So we have the scoring system here for the GSE, GSE-MI for patient reports of memory function. And it was found that ECT had lower scores relative to ketamine by a significant amount. And there were a number of other indicators demonstrating that there were some cognitive symptoms in patients that were treated with ECT relative to ketamine. So further details on outcomes included a number of other parameters. We know that the quality of life scale was basically similar for both ECT and ketamine. So the quality of life after ECT and ketamine was very similar. We also know that in this trial of 403 patients, that virtually the similar amounts of ketamine patients and ECT patients finished all their sessions. But relapse, which was defined as a QIDS 16 score greater than 11, occurred in a significantly larger number of ECT patients relative to ketamine patients. So at month number 1, 19% of ketamine patients relapsed back into depression, whereas 35% of ECT patients relapsed back into depression. By month 6, 34% of the ketamine-treated patients actually relapsed back into depression, and 56% of ECT patients relapsed. So a larger number of ECT patients seem to relapse back into depression over the 6 months of follow-up after this particular study. So the summary was as follows. The trial showed that there was a non-inferiority of ketamine therapy with ECT, the gold standard of depression treatment, with respect to the primary outcome of treatment response with the QIDS scoring system, and that there was a decline in memory performance that was greater than in the ECT group than with ketamine at the end of treatment, but by 1 month, they were similar according to the study. And the quality of life was similar as well in both ECT group and the ketamine therapy group. Now, just a couple of notes that, this was different in terms of ECT relative to ketamine versus other studies that were done. ECT had been shown in European studies to be better than ketamine. However, the study protocols were a lot smaller. There were fewer randomized patients in those trials. This was a very large study, actually. And the ECT studies done over elsewhere were in inpatient settings. And the individuals were generally older and had bilateral treatment and were psychotic depression in those cases. These particular patients were non-psychotic depression, and there was a larger sample size in this particular study.